On the way to the scene, the EMTs will be thinking about BSI, safety, number of patients, mechanism of injury, nature of the illness, how many resources we might need, and if we need to bring in spinal mobilization equipment. Upon arriving at the scene, we'll do a scene general impression, looking for any safety hazards. We'll be making note of any concerns about patient condition, well lighting, environmental factors such as temperature, access to the patient, as well as safety concerns. As we approach the patient looking for a mechanism of injury that could indicate the need for spinal mobilization, such as head trauma, severe trauma, such as severe mechanism of injury, hangings, water-related accidents. In this scene, we are told that the C-spine is not required. So I approach the patient. Hello, sir. My name is Matt. I'm an EMT student with Cosumnes River College. We're here to assist you. Sir, can you hear me? Sir, we're EMT students from Cosumnes River College trying to help you. Do some painful stimulus. The patient is unresponsive to pain. Going to check the carotid pulse for up to 10 seconds, as well as checking skin signs for moisture, color, and temperature. Patient has a strong carotid pulse. Skin is cool, pale, diaphoretic. Considering the patient is in shock, going to contact ALS for an unresponsive adult male. Going to be checking the patient's airway and making sure that the patient has an adequate airway. Using a light pen. Opening the patient's mouth, visualizing the airway, smelling for ketones or any unusual alcohols, listening for gurgling, snoring, and stridor. The airway seems to be patent, but the patient is unresponsive to pain with a strong carotid pulse. Going to consider an airway adjunct of an OPA. Going to be measuring from the corner of the mouth to the angle of the jaw. Patient is unresponsive and patient has no gag reflex. Open the mouth, insert upside down, doing a 180-degree rotation, making sure the flange rests on the lips. The patient gags, follow the contour of the airway, and remove the oropharyngeal airway. Going to visualize the mouth. I notice that there's emesis in the back of the mouth. We need to apply suction. If we had multiple healthcare rescuers, we could log roll the patient. I'll be using a Yankauer, rigid suction catheter or tonsil tip, checking the suction unit, measuring from the corner of the mouth to the angle of the jaw, opening the mouth, inserting without suctioning, suctioning back and forth without removing for no more than 15 or 10 seconds for an adult, 10 seconds for a child, 5 seconds for an infant. The airway appears to be clear at this time. Inserting a nasal pharyngeal airway. First, I will palpate the patient's head, looking for contraindications such as trauma, checking for battle signs or blood coming out of the ears and the nose or the mouth, checking for any bruising or trauma to the head. Going to measure my nasopharyngeal airway from the tip of the nose to the angle of the jaw or the earlobe. I'm going to apply water-soluble lubrication. In this case, I will use mannequin spray. I'll be inserting the bevel towards the septum. Insert while rotating back and forth. If I was placing this in the patient's left nair, I would simply rotate upside down with a bevel facing the septum. Once I'm in 1 or 2 inches in, I would rotate and place in. Patient accepts the nasopharyngeal airway. Patient is not breathing adequately. Going to provide bag valve mask ventilation. With the adult bag valve mask, this provides 21% oxygen on room air. First, give 2 initial breaths to make sure we have rise and fall. Continue with ventilations at 1 breath every 5 to 6 seconds. Visualizing for rise and fall. Looking up to 15 liters, which provides 90 to 100% oxygen concentrations. Continue ventilating. Making sure we have adequate rise and fall of the chest. 1 breath every 5 to 6 seconds. Child would be 1 breath every 3 to 5. Infant, 1 breath every 3 to 5. Their liter flow would be at 10 liters. I will expose and examine, checking for any trauma to the chest that needs to be fixed. Also visualizing good rise and fall of the chest. 1 breath every 5 to 6 seconds. Scanning the patient for any arterial bleeding, gross hemorrhaging, as well as looking for any gross trauma, checking for incontinence. Going to continue ventilating 1 breath every 5 to 6 seconds, looking for bilateral rise and fall of the chest. When I have additional resources, I would do a patient priority. This is an unstable adult. They're unstable because of airway, breathing, and mental status concerns. We'd want to be on scene for no greater than 10 minutes. We'd want to package the patient, get a detailed history as best as possible, considering rapid transport, calling ALS to re-advise them of the patient's status, and we would definitely need to get baseline vital signs. If the patient was going to be intubated, we could do cricoid pressure, which is finding the cricoid membrane, which is inferior to the thyroid cartilage, putting 10 to 12 pounds of weight of pressure on the cricoid cartilage. This is also called Selleck's maneuver, and is used for endotracheal intubation, but is no longer used for CPR.